Imagine buying a car this way. You sign the papers, take the keys, and drive home without seeing the price. 3 weeks later, one company sends a statement. Another sends a different number. Then a third envelope tells you what you actually owe. In almost any market, that would sound absurd. In American healthcare, it is an ordinary medical bill. The confusion begins because a medical bill looks like a price tag. It is not. It is the ending of a process that started long before the patient entered the room. The hospital set a list charge. The hospital and insurer negotiated a different rate. The insurance plan applied its rules. Only then did the system calculate the patient's share. Federal rules recognize several hospital prices for the same service. The gross charge, a discounted cash price, payer-specific negotiated charges, and the lowest and highest negotiated charges without naming the payer. Those are not small variations around one universal price. They are different answers to the same question, depending on who is paying and which contract controls the transaction. The gross charge is the hospital's starting number, the amount listed before discounts. It can appear dramatically high on a statement, but many insured patients do not pay it. The insurer points to a contract and reduces the claim to a negotiated amount. That first number still matters, however. It anchors the bill and can shape what people without a strong contract are asked to confront. That contract was negotiated by institutions, not by the person receiving care. A large insurer may promise access to thousands of members. A hospital system may control essential facilities or specialists in a region. Each side brings leverage. The final rate reflects that bargaining position, which is why two insurers can receive different prices for an identical service at the same hospital. After the claim reaches the insurer, the key number becomes the allowed amount. HealthCare.gov defines it as the maximum amount a plan will pay for a covered service, sometimes called the negotiated rate. It is not automatically the amount the insurer pays. First, the plan asks how much of the deductible has been met and what co-payment or co-insurance rules apply. Suppose the allowed amount is $1,000. If the patient has not met a deductible, much of that amount may remain with the patient. If the deductible has been met and the plan uses 20% co-insurance, the patient's share may be $200. The clinical service did not change. The contract and the benefit calendar changed the bill. Then come two documents that are easy to confuse. The insurer sends an explanation of benefits, or EOB. CMS is explicit, it is not a bill. It shows the charge, the plan's adjustment, what the plan paid, and the patient balance. The provider sends the actual bill. CMS says that bill should not be higher than the EOB's patient balance. This means the person in the next appointment slot can receive the same scan in the same machine with the same technician and generate a different allowed amount. One plan negotiated aggressively, another accepted a higher rate. A cash price may be different again. The machine delivered one image. The payment system produced several economic realities around it. The gaps can be large. RAND analyzed claims from more than 4,000 hospitals and found that in 2022, employers and private insurers paid hospitals an average of 254% of what Medicare would have paid for the same services at the same facilities. That is a study average, not every hospital's price. But it reveals how far negotiation can move the number. Why would a plan accept it? Because healthcare is not a normal shopping trip. In an emergency, the patient cannot compare. In scheduled care, the physician's referral, network, and location narrow the options. A dominant hospital may be difficult for an insurer to exclude. The negotiation is not only about the cost of a procedure. It is about who can credibly walk away. Hospitals have been required to publish standard charges since 2021, including negotiated and cash prices. But a data file is not the same as a usable answer. The Government Accountability Office found that complex pricing, inconsistent formats, and concerns about incomplete or inaccurate data made comparisons difficult. Even a correct rate may not include the patient's current deductible or every provider involved. The rules have tightened. Beginning in 2026, CMS replaced an estimated allowed amount field with actual median, 10th percentile, and 90th percentile allowed amounts, plus the number of observations used. Enforcement began in April. That gives researchers, employers, and comparison tools better raw material. It still does not turn an emergency room into a supermarket aisle with one price on the shelf. Some of the worst surprises now have federal limits. The No Surprises Act protects people with most private coverage from many out-of-network bills for emergency care, certain services at in-network facilities, and air ambulances. But the boundary matters. It does not erase deductibles, co-insurance, uncovered services, or every network dispute. An expensive bill and an illegal surprise bill are not always the same thing. Uninsured and self-pay patients have another protection for many scheduled services: a good faith estimate. CMS says that when a final bill from a provider is at least $400 above that provider's estimate, the patient may qualify for a federal dispute process. That right does not make every estimate perfect. It creates a line the billing system can be asked to defend. The stakes continue after the envelope arrives. The Consumer Financial Protection Bureau reported that, as of June 2023, 15 million Americans still had more than $49 billion in medical bills on their credit reports. The agency has also documented complaints about duplicate, inflated, already paid, and unsupported charges. Not every bill is wrong. Every bill should be readable enough to verify. So begin with 3 comparisons. Match the provider bill to the EOB's patient balance. Check that the service and network status match what actually happened. If the number still does not make sense, request an itemized bill and ask the provider or plan to explain the adjustment. For possible surprise billing or estimate disputes, use CMS medical bill rights resources rather than guessing from the largest number on the page. The next time a medical statement arrives, do not ask only, "Why is this so expensive?" Ask which number was the list charge, which contract created the allowed amount, which insurance rule created your share, and whether the final bill matches the EOB. The bill is the last page of a negotiation you never saw. Our next investigation follows another price that can rise without anything happening to you: car insurance. Subscribe and follow the money. See the system.